Okay, I think we can start. Tonight we have Dr. Olivier Glehen from Lyon in France, who will be talking about treatment of peritoneal surface malignancies, curative and preventive treatment. Thank you, Dr. Olivier, for joining us in our humble webinar, and the floor is yours.
Thank you very much, Hisham, and once again, many thanks for your invitation. It's always for me a real pleasure to speak about peritoneal surface malignancy that empty all my life. This is my disclosure. So I think that peritoneal surface malignancies is probably one of the area during the 20 or 30 past years for which we did the most important progresses in oncology, because we moved from a treatment that was systematically palliative to a curative treatment with the development of cytoreductive surgery, peritonectomy procedures, but also with the development of intraperitoneal chemotherapy. You all know the IPEC, little less the PIC, and came now the PPAC, which is a new modality of treatment of peritoneal surface malignancy. And I think that now we can speak about curative treatment of peritoneal surface malignancy, and it was totally impossible 20 or 30 years ago. So I have the privilege and the chance to be at the head of expert centers in the management of these very difficult pathologies. Thanks to my boss, Professor Gilly, who did the first IPEC in Europe in 1989. We have now the experience of more than 3,000 IPEC, and we are performing more than 250 cytoreductive surgery per year because of this beautiful team. When you look at the results in our institution, you can see that each 5 years, we improve and we increase the median survival, whatever the peritoneal surface malignancies was. And we moved from a median survival of our patient that was a little more than 6 months to median survival that reached now more than 60 months. Of course, the prognosis is radically different regarding the pathology that we are treating. At the top, we have the pseudomyxoma peritoneal, and on the back, the gastric peritoneal surface malignancy. But you will see also that for this poor prognosis peritoneal surface malignancy, we can obtain some long-term survival by an appropriate selection of patients. And we may obtain now not only 5 years survival, but also 10 years survival for many patients. So peritoneal surface malignancy is, for most part, a local regional disease. So there is a strong rationale for a local regional treatment. We will treat schematically the macroscopic disease with the surgery, the microscopic disease with the intraperitoneal chemotherapy, and most frequently with IPEC. But for many diseases, we will have to take into account also that these patients will also evolve with systemic metastasis, and we will have to integrate in the overall management the use of intravenous chemotherapy and now new drugs, new targeted therapy. Recently, we participate to this interesting review on Nature that summarized the therapeutic strategies for all the peritoneal surface malignancies. And you can see quickly that we have to choose for every etiology the good sequence between systemic chemotherapy, intraperitoneal chemotherapy, surgery, and that each part of this therapeutic strategy have a strong place if you want to do a curative treatment, but also because curative treatment is not allowed for all the patients if you want to do an appropriate palliative management. So the most important part of the curative treatment is, of course, the surgery. And we gain so many things with the development of parietal peritonectomy that you have to perform when you have the disease on the parietal peritoneum, as you can see here under the diaphragmatic cupola, or here in the anterior peritoneum with the scar. It's sometimes most difficult to choose what to do when you have to do organ resection, and you will have to perform organ resection when the tumor nodules involve the visceral part of the peritoneum. The rationale of the intraperitoneal chemotherapy of the IPEC, you probably all know this very well. Just to summarize, there is a pharmacokinetic advantages of intraperitoneal chemotherapy that is delivered directly in contact of cancer cells. There is a demonstrated effect of hyperthermia at level more than 42 degrees. There is a synergistic effect between hyperthermia and some anti-cancer drugs like cisplatinum, mitomycin C, and you administrate this chemotherapy immediately after the surgical procedures, after the removal of the macroscopic disease. You will avoid like that the phenomenon of cancer cells entrapment, but you will have a real inconvenience in comparison to systemic chemotherapy is that this is a single shot treatment. So you have to eradicate the microscopic disease in one time. Schematically, you have two big techniques of IPEC that were developed: the open technique, the Coliseum technique from Paul Sugarbaker, but also the closed technique that was developed by Marcello Orderaco from Milano and by our team in Lyon. So now, to speak about the candidates for a curative treatment for peritoneal metastasis. You will have to take into account first the patient conditions. Secondly, the center. I think that this kind of therapeutic management cannot be done everywhere, and you should have specialized surgeon, multidisciplinary team, and the possibility to manage the intraperitoneal chemotherapy. You will also take into account the tumor, so the etiology of your peritoneal disease. For some of them, the response to systemic chemotherapy, the pathology, and more now, the molecular factors. And you will have to take also into consideration the peritoneal disease dominated by the extent of the disease, appreciate now in every team by the PCI, to evaluate the possibility that you have to perform a complete cytoreductive surgery, and also to take into account the presence of the extraperitoneal disease. My first message for current practice is that now, with the development of all the therapeutic strategies, you should think for each patient about the curative treatment of peritoneal metastasis at the time of the diagnosis and not after several surgical procedures or several lines of systemic chemotherapy. You should appreciate initially if there is a possibility for curative treatment. Of course, you will not be able to perform some complex procedures in every patient. This is still an aggressive therapeutic approach with high rate of mortality, a high rate of morbidity. So you will have to do an evaluation of the general status and of the motivation of the patient, of his psychology, because it's very important to do this fight with a patient that is able to tolerate it psychologically. So performance status 0 to 1, no severe cardiac, respiratory, or renal disorders. Usually you have to schedule your procedures 1 month following the last cycles of systemic chemotherapy. And one question could be asked is the age. Age is or no a contraindication of a combination of cytoreductive surgery and IPEC. The answer is no. We did a big retrospective study in the French registry, and we compared patients older than 70 years and younger than 70 years. And you can see that even if the mortality rate is higher, the difference was not significant, and the morbidity rate was really equivalent. So at the beginning of the experience of this curative treatment, age was an absolute contraindication over 70 years. It's absolutely not a contraindication now. What about the centers? This is complex procedures that requires surgical skills, surgical experience, and the possibility of management of intraperitoneal chemotherapy. So this kind of procedures should be done in expert centers. This is complex, this is costly, this is long. You will have into expert centers a better patient selection, a lower complication rates, and you will have also more curative treatment with a higher rate of complete cytoreductive surgery, which is the crucial prognostic factor. Of course, it's sometimes difficult when you are into the abdomen to choose the good way of your surgery, closing or doing an appropriate procedures. I like Western, and I think that this illustration illustrates well the position of the surgeons in face of a peritoneal surface malignancy. It can, you should do for every patient the good one and do the appropriate surgery that leads to appropriate risk of postoperative complication that will not give some big sequela to your patient and that offer an appropriate and a good survival, good survival. Because of this, the French government decided to ask to us to build a network of expert centers and of reference centers, especially for the peritoneal, the rare peritoneal surface malignancy. And this network is called RENAP. We did a big RENAP network following the RENAP that incorporate not only centers specialized in the management of rare peritoneal surface malignancy, but also on every peritoneal surface malignancy. Surgeons are not alone. You can see that we also established pathologist group, Renapat and Mesopat for Mesothelioma, and also a radiologist group, because now even it's difficult today, it's still difficult today to appreciate the extent of the disease. The radiologist and the functional imaging did many progresses that allow us to select appropriately our patient. So now, which etiology? Peritoneal mesothelioma, I think that there is no discussion for this indication. You can see in blue the results of peritoneal mesothelioma treated by systemic chemotherapy only. The median survival did not exceed 1 year. And when you can apply cytoreductive surgery and IPEC, the median survival is systematically more than 50 months. It was reported in the Journal of Clinical Oncology in the international experience, and you can see that the IPEC was an independent prognostic factor in this big registry that validated the gold standard of this therapeutic management, cytoreductive surgery and IPEC. For pseudomyxoma peritoneal, it's exactly the same. You can see the results of the French registry that showed that IPEC doing by closed or open procedure did better than intraperitoneal chemotherapy without hyperthermia. It was also reported, the international registry was also reported in the Journal of Clinical Oncology, and you can see here the major role of an adequate, complete or subcomplete cytoreductive surgery. This is many times complex procedure. You can see here an example of one patient with many tumors with the classic redistribution phenomenon. So 80% of the tumor is in the periphery of the abdomen. Sometimes for these patients, when you open, you cannot exactly know where you are, but with experience and in this patient, we were able to perform a subcomplete cytoreductive surgery that was combined with IPEC. And this patient was still alive, is still alive 20 years after the procedure. But we will speak now about the most common indication, the colorectal peritoneal metastasis. We don't have to forget that every 10 years, we gain approximately 10 months in terms of median survival in the curative treatment. And we obtain 40 months with the use of perioperative systemic chemotherapy and cytoreductive surgery only without IPEC in the French randomized trial. What are the reasons for this success? Of course, the key, and I will say it many times during my speech, this is the cytoreductive surgery. After that, it is the patient selection. We operate now, not the patient that we operated in the past. The progress, of course, of the perioperative systemic chemotherapy, and as I said, the establishment of specialized centers involved into peritoneal surface malignancy. But what about the role of intraperitoneal chemotherapy and IPEC? I will speak about this. When you are giving only systemic chemotherapy for peritoneal metastasis, you can see that the median survival is lower for peritoneal disease than for hepatic metastasis than for lung metastasis. And the median survival in peritoneal metastasis treated with only systemic chemotherapy is approximately 16 months. You all know these randomized trials that validated that the combination of cytoreductive surgery and IPEC did better than systemic chemotherapy. This is the Netherlands study that was stopped after 2 years because of the big difference in the intermediate results. You all know also that in these case control studies, cytoreductive surgery did better than systemic chemotherapy in localized disease, in more evolved disease. The American Society of Peritoneal Surface Malignancy also reported this tremendous experience of more than 1,000 patients. They did some prognostic subgroups regarding clinical symptoms, extent of the disease, pathology, and you can see that whatever is the prognostic group, cytoreductive surgery and IPEC do better than systemic chemotherapy alone. For the patients that we select now, the PS-DSS1 with localized disease, well-differentiated tumor, no clinical symptoms, cytoreductive surgery did better. But for more poor prognostic patients, also you can see that this kind of therapeutic association did also better. It was demonstrated that it's possible now to cure a patient with a peritoneal metastasis from colorectal cancer in approximately 16 patients that we selected. And when you apply the selection by using a neoadjuvant systemic chemotherapy in expert centers, the median survival reached more than 60 months. So because of all these results, in many countries, the national guidelines was that cytoreductive surgery and IPEC should be considered as the standard of care for colorectal metastasis, peritoneal colorectal metastasis. But all the studies that we had compared the combination of cytoreductive surgery and IPEC to systemic chemotherapy. This is the reason why we did in France these randomized trials that included patients that had all cytoreductive surgery. They all had modern systemic perioperative chemotherapy, and the IPEC was randomized intraoperatively. We decided to use the protocol with high dose of oxaliplatin for a short period, 30 minutes. And we had the two big surprises. The first surprises was that the cytoreductive surgery alone may reach a very impressive median survival of 41 months. And the second surprise was that the IPEC did not anything in terms of long-term survival. So for many oncologists, for many general surgeons, the conclusion of this study was IPEC did not improve prognosis of patients curatively treated for colorectal peritoneal metastasis, but it was not the appropriate conclusion. The appropriate conclusion is that this protocol with a high dose of oxaliplatin for a short period that did not improve the prognosis of these patients. Following this study, we had two more studies that evaluated this protocol, but in a prophylactic setting. The Prophylactic study for patients at risk, they all had adjuvant FOLFOX, and patients were randomized between follow-up and second look with IPEC. This study was negative. Colorectal study, the Netherlands study, also used the same protocol of high dose of oxaliplatin for a short period, and they did IPEC only 44 or perforated tumors just after the removal of the primary tumor. And they failed also to demonstrate any benefit of the procedures. So the history of, So IPEC was, that we are calling now the quick ship, was probably not the appropriate IPEC. And there is no experimental rationale for hyperthermic augmentation with oxaliplatin. The effect of oxaliplatin alone, even by intravenous administration, is less than 20% of response rate. We had the bad surprise to have a very high rate of hemorrhagical complications. And you know that hemorrhagic complications lead to complications that have a poor influence on the survival, transfusion that has also a bad influence on the survival. Many of our patients, more than 80%, received FOLFOX before the surgery. And we all know also that using FOLFOX for many cycles induce oxaliplatin resistance. There is also an insufficient duration, and we know that the duration of drug exposition, the duration of hyperthermia of 30 minutes is not sufficient. And moreover, we put oxaliplatin in an adequate carrier solution because glucose perfusate is a procarcinogen. So, following these randomized studies, is it the end of IPEC? Probably no, because there is some clinical studies in favor of IPEC, which validate the potential benefit of adding IPEC to cytoreductive surgery. Firstly, the pseudomyxoma peritoneal, and this very interesting international registry that used the propensity score to make two groups comparable, and you can see that IPEC did better than cytoreductive surgery alone. Whatever the pathology is, whatever the completeness of cytoreductive surgery is, and the best protocol was the combination of cisplatinum and mitomycin C. I already show you this experience in peritoneal mesothelioma, in which IPEC was an independent prognostic factor. The IPEC used in this pathology is for 90 minutes and is a combination of cisplatin and doxorubicin. And you all know these studies that were reported in the New England Journal of Medicine that evaluated IPEC in ovarian cancer, in interval surgery. For the first time, one procedure increased the median survival of more than 1 year, and the IPEC use was cisplatinum one more time with appropriate dose and for appropriate duration. We also reported this experience in gastric cancer that was also published in the Journal of Clinical Oncology. It was a retrospective study, but also using a propensity score and the IPEC that demonstrated its benefit was also performed for 90 minutes with cisplatinum and mitomycin C. So is it the end of oxaliplatin use for IPEC? No, no. But we should use one protocol that does not lead to hemorrhagical complications. So with lower dose, the American colleagues reported interesting randomized trials that showed that oxaliplatin with low dose did not increase the complication. And Kurt van der Spitten, that did not publish already his results, demonstrated also in his lab that if you put cancer cells with oxaliplatin for 30 minutes, you have no apoptosis, but after 2 hours, you have the apoptosis. So what is the solution? Mitomycin C, this old drug. The problem into the literature is the number and the heterogeneity of protocol that you can find. You have many protocols and the same number of protocols that you have institutions specialized into peritoneal surface malignancy. The American Society tried in this interesting retrospective study to compare the use of IPEC with mitomycin C and oxaliplatin, and demonstrated that in the patients that we are selecting now, the mitomycin did significantly better. But other institutions also compared their experience with oxaliplatin and mitomycin C, and they compared the most recent patients for which they used oxaliplatin to the old patients that were treated with mitomycin C. So this comparison cannot lead to any conclusion. We had this most recent registry of, you can see more than 2,700 patients that tried to compare the oxaliplatin and mitomycin C, and you can see that once more time in this large registry, we cannot draw any adequate conclusion. But in this big registry, it appears that the use of combination of drugs appears to do better than the use of single drugs. So I think that it is a good illustration of the current situation of idea and thoughts about the use of IPEC in colorectal cancer. This is the reason why we decided to do this big Delphi IPEC regimens, this international project. We did a review, but a complete review of the literature with the PICO method, and we decided to ask to 144 international experts what they recommend in terms of current practice for all peritoneal surface malignancy with the use of IPEC in several etiologies. When you look at the analysis of the literature, it appears that the mitomycin C-based regimen alone or combined with cisplatinum did better in terms of reducing of a postoperative complication and in terms of prolonged survival. After the first round of the vote, 84% of experts recommended the use of IPEC with mitomycin C regimen, but 82% considered that it was essential to conduct new randomized trials. This is the reason why we decided with our Spanish colleagues to do a new randomized trials that was very close from the Prodigy 7 trials, and that compared cytoreductive surgery alone versus cytoreductive surgery with IPEC with an appropriate protocol of mitomycin C. And to get our results more quickly, we decided to change the principal objective and to evaluate the survival without peritoneal recurrence. So now to select our patients, should we do upfront cytoreductive surgery or should we use neoadjuvant systemic chemotherapy? I don't know exactly what is the situation in Egypt, but in France, when you have a peritoneal disease from colorectal cancer, most of the patients start with systemic chemotherapy. Despite this kind of results from our Belgian colleagues that showed in their experience that the use of upfront cytoreductive surgery did better than using neoadjuvant systemic chemotherapy. But this is a retrospective study. The PCI that has a very important prognostic factor was lower in the upfront cytoreductive surgery group. We don't have to forget that in the Prodigy 7 French study, the patients were really selected because more than one patient over 4 that was included in the study was not randomized because he progressed under systemic chemotherapy. So for these patients that progress under systemic chemotherapy, what would be the results with the upfront surgery? This is an answer that we do not have. And when you look at these curves that were not published in the Lancet of Oncology, you can see that the patients that had the best results were the patients that were operated upfront without any systemic chemotherapy. So, of course, the patients are not the same, but we should have to keep this in mind by choosing our therapeutic strategy. In URSUD, we decided in this experience to try to evaluate the role of this neoadjuvant systemic chemotherapy by the comparison of several regimens, the bead therapy, the tree therapy, and the bead therapy with targeted therapy. You can see that the morphologic response and the complete and major pathologic response were equivalent in all groups. But when you look at the survival, the FOLFIRINOX regimen did better than the B therapy and did better than the B therapy with targeted therapy. Of course, these results should be confirmed in randomized trials. And as always, our Netherlands colleagues will be in charge of these very interesting phase 3 trials that will compare one strategy with upfront cytoreductive surgery and IPEC, and one other with the use of neoadjuvant systemic chemotherapy to validate this strategy. So what should we do now in colorectal peritoneal disease? Probably we can use organoid to choose the better intraperitoneal drug. We should also develop other things than IPEC, like vaccine nanoparticles. But I think that the most important things is to identify to each patient the risk that he has to develop peritoneal recurrence, to develop systemic recurrence. And we should, of course, use for this the moleculars, the genetic factors, the DNA, the circulant DNA, into the blood, but also into the peritoneum. And when we will be able to establish at the diagnosis for one patient what is the major risk, we will be able to apply appropriate sequence of systemic chemotherapy of intraperitoneal treatment. One word now about a more questionable indication, the gastric peritoneal metastasis. Why it is more questionable? Because you induce a big part of quality of life, because as you know, you will have a strong impact of gastrectomy that you should perform if you want to do a complete cytoreductive surgery. So you will have, particularly in this indication, to balance between survival, chance of cure, and toxicity and quality of life. To answer to the first question, is it also possible to cure a peritoneal metastasis from gastric cancer? The answer is yes. Not so many, but 10% of the patients that we selected in France were cured with no disease following 5 years. All were synchronous. As you can see, the PCI was very low, less than 6. All were treated by complete cytoreductive surgery, but you can see that some patients had this poor prognostic pathology, dependent cancer cell signature cells. I already showed you these results of the CytoShift trials that we reported in a Journal of Clinical Oncology that compared with a propensity score cytoreductive surgery and IPEC to cytoreductive surgery alone. And we were able to make 2 groups strictly comparable, except for one thing, the PCI. And the PCI, the median PCI, was 6 in the cytoreductive surgery group and only 2 in the cytoreductive surgery and IPEC group. And despite this disfavorable prognostic impact, the IPEC did better in terms of median overall survival and did better in terms of disease-free survival. And IPEC did not increase the morbidity and the mortality rate. So, as I already showed you, the IPEC that was performed majoritarily was with cisplatinum and mitomycin for 90 minutes. We decided to go a little more, little longer with the evaluation of the pathology. Should we operate these patients with linitis and localized peritoneal disease? And should we use the same PCI cutoff that we are using for well or moderately differentiated adenocarcinoma? And as you can see on the survival curve, the PCI cutoff for patients with poorly cohesive carcinoma for linitis and dependent cancer cells is probably should be less than 7. but you can increase this PCI cutoff in case of well or moderately differentiated tumor. One word now for some surgeons that are doing peritoneal disease malignancy, because they will be solicited also for unusual indication of cytoreductive surgery and IPEC. And we decided with the PSOBI group to perform a big registry to try to answer in this rare pathology or in this unusual etiology. One word about, cholangiocarcinoma. Cholangiocarcinoma from the heel or from the gallbladder. And you can see that in strictly selected patients that were compared to a group of patients that receive only systemic chemotherapy, we found some long-term survival and some difference with strategy using only a palliative intent. We also have, as you can see, some long-term survival in case of complete cytoreductive surgery in urachus tumor, in some pancreatic tumor, in some hepatocarcinoma, or in some rare ovarian tumor. So when you are in face of a peritoneal disease, even if it's a unusual indication, it's an indication with a poor prognosis, primary tumor. If your patient is young, if your patient have a good tumor biology, if your patient is controlled for a long time during under systemic chemotherapy, and if your patient is resectable with a localized disease, I think that you should consider a curative treatment. You should select on two major prognostic factors. The first and the most important is the surgical residual disease, and the second is the disease extent. This is the case in colorectal carcinomatosis. In pseudomyxoma, you can see the major role of complete cytoreductive surgery, but this is the case also on gastric peritoneal disease and on ovarian peritoneal disease. We decided to establish a software to help the surgeons that are not using this tool regularly in order for them to complete the PCI, which is a crucial prognostic factor, and to help expert center to appreciate the disease extent. This software allows you to incorporate into your operative report a PDF format that simplifies the things. The PCI, the disease extent, is crucial in colorectal peritoneal disease. Each time, in every registry, each time you gain 1 point of PCI, you are losing 5% of 5 years survival rate. This PCI is also crucial, of course, in gastric peritoneal disease. But the most important thing is for all cases to appreciate the possibility of complete cytoreductive surgery on morphologic exam, but also intraoperatively. You should describe as precisely as possible the degree of involvement of the small bowel, because this is the small bowel that will be your limit. So for that, the laparoscopy is a pivotal tool. We are not using laparoscopy systematically before curative treatment in our institution. We are using it systematically for gastric, for colorectal when you have any doubt in a possibility of complete cytoreductive surgery, and systematically in peritoneal mesothelioma. This laparoscopy will appreciate the extent of the small bowel involvement, and you have to be very aware, especially in the pathology that include independent cancer cells, to this small mesentery involvement that you cannot sometimes detect on a regular laparoscopy. So each time I have this poor prognostic pathology, I ask to each member of my team to do a very small laparotomy to be able to do palpation of this small bowel. Okay, so now what about the extraperitoneal disease? Is it an absolute contraindication of a curative treatment? The answer is no, especially if this extraperitoneal disease is chemosensitive. We have a lot of experience that were reported of peritoneal metastasis combined with liver metastasis that are giving exactly the same survival curve after 3 conditions: less than 3 metastases, limited liver surgery, and chemo response of liver metastasis. We did in our database also the comparison of each site of metastasis. And you can see on more than 500 patients that the presence of liver metastasis has no, or one site of metastasis did not influence the prognosis. But each time you have 2 sites of metastasis, so liver and lung, the prognosis is significantly lower. The liver metastasis had exactly the same survival curve than the peritoneum, but when you have other metastases like lymph node metastasis, for example, the survival is bad. Of course, now we have to use the molecular tumor factors, and we have to choose our perioperative systemic management, the RAS and BRAF mutation, the MSI, of course, and probably we should not operate now the MSI patients because this mutation has a strong influence on the prognosis. But even if BRAF mutation is a strong, bad prognostic factor, this is not an absolute contraindication in case of localized resectable disease. So in summary, you have to take into consideration all these conditions to select your patient and to choose an appropriate curative treatment of peritoneal metastasis. You should probably now, as the medical oncologists are doing with the systemic chemotherapy, apply a personalized therapeutic management. I will finish with some words about the prophylactic and the proactive management, because the peritoneal disease is still a poor prognostic evolution, and if you can prevent it, you will improve the prognosis of your patients. For colorectal metastasis, we know the patients that are at risk of peritoneal recurrence, the localized peritoneal metastasis, the ovarian metastasis, the T4 tumor, but not all the T4 tumors. The T4 tumors that are mucinous, the T4 tumors that are combined with a big lymph node involvement. And we know also that this proactive strategy, when you are using a second look following a FOLFOX regimen, in this high-risk group patients, you will find approximately half of our patients that will have peritoneal disease, whereas there is nothing on the morphologic exam. We have some case control studies that demonstrated that in this group of patients, IPEC increased the peritoneal recurrence at 5 years and the overall recurrence. It was demonstrated especially by our Italian colleagues, Marcello De Racco and Paolo Sammartino, that showed that peritoneal recurrence was decreased by the use of IPEC before the development of peritoneal disease. But we had, as I already showed you, 2 randomized trials that was using the quick ship protocol that failed to demonstrate that this strategy should be applied. Prophylactic trial, the French study that showed no difference in disease-free survival at 3 years. But I can tell you that there is some problems with this study. That was no centralized monitoring on the principal objective. So the group were absolutely not comparable. It was, the patients were randomized at the beginning. So more than 10% of patients did not have second look in the experimental group, and they were not excluded from the survival analysis. We did IPEC with oxaliplatin on patients that received 12 cycles of FOLFOX. So you all know this problem of oxaliplatin resistance. And we probably included a lot of patients that have not a so high risk of recurrence. If you want to demonstrate that something will reduce risk in a randomized trials, you should select patients that should have high risk. Otherwise, you have to include too many patients. We also have this Netherlands study, the Colorectal study, that evaluated IPEC just following the removal of a primary tumor. And this study also failed to demonstrate the benefit of using IPEC. That was also the quick IPEC with a short duration of oxaliplatin. From my point of view, it was not the good patients. And for Colorectal, it was too early. And for Prophylactic, it was too late. For Prophylactic protocol, you will have many patients that develop their peritoneal metastasis during the FOLFOX and that were not included into the protocol. And moreover, as I said, IPEC with oxaliplatin was performed in patients that progress on FOLFOX. So it was not an adequate therapeutic strategy. In Colorectal, the IPEC was too early. T4, a perforated tumor, have perhaps a risk of peritoneal recurrence, but these tumors has also a high risk of systemic recurrence, of liver, of lung, of lymph node metastasis. And if you delay the start of systemic chemotherapy, you will have a poor impact on your survival. So I think that the good way to do is probably like this. And I hope that we will be able to start this very interesting study in France. For patients, we decided to select really patients that have a risk of peritoneal metastasis development. So patients that have a risk of more than 50% of peritoneal recurrence. For all these patients, we will start FOLFOX. So we will apply a systemic treatment. And we will do the second look in an interval position. So with this strategy, we will exclude patients that progress extraperitoneally and they will receive another regimen of systemic chemotherapy. And we will avoid this number of patients that progress under FOLFOX. And following the procedures, the patients will receive the last cycles of systemic chemotherapy to complete the recommended 12 cycles of FOLFOX. One word to finish about gastric cancer and preventive treatment of peritoneal recurrence. You all know that approximately half of patients with gastric cancer will develop in their history a peritoneal recurrence. And we know the factors that are associated with this high risk: laminitis, lymph node involvement, serosal involvement, and positive cytology. When you look into the literature, in all meta-analyses that were performed, you can see in each trial a benefit of using IPEC as prophylaxis of peritoneal recurrence, with, of course, an impact on overall survival. The problem of this meta-analysis is that all were included many Asiatic trials. And we all know that the Asiatic gastric cancer is not exactly the same gastric cancer that we have in the Western countries. This is the reason why we decided to conduct in France the Gastric trials for patients with T3, T4 tumor and plus and or positive cytology. They all had a laparoscopy to eliminate patients and to exclude patients with peritoneal disease. They all had the perioperative systemic chemotherapy, which is the standard of care in Europe. And during the curative gastrectomy, they were randomized between curative gastrectomy, between IPEC with oxaliplatin and curative gastrectomy alone. We already have the results of the mortality and the morbidity, but as the principal objective is the 5-year survival, we do not have the results in terms of long-term survival, which is the principal objective. One remark, we had to include more patients because despite the fact that we performed systematically a laparoscopy, we found some patients with peritoneal disease during the curative procedures in approximately 12% of patients. I will finish with this last diapositive to tell you that we did so many progresses during the past years. We moved from palliative to curative and preventive treatment of peritoneal disease. I think that during the next 10 years, the answer will probably not come from the randomized trials. We will have to identify the patients that should receive the appropriate local regional management, the appropriate cytoreductive surgery, and the appropriate intraperitoneal chemotherapy. Thank you very much for your patience and your attention.
Thank you, Dr. Olivier. We start by taking questions from the audience. Please, if you have a question, raise your hand. Dr. Medhat Khafagi.
Yes, thank you for your excellent lecture. And you alluded to a cure rate in peritoneal surface malignancy. I think the cure here is due to recovery of the immunity of the patient. Because if you are excising peritoneal surface malignancy, there is no safety margin around your excision. You have R0 resection, but really you have no safety margin around the peritoneum involved. And so I think we have to compare those patients cured with those patients recurred by doing some immunity studies like CD4 and the CD8 cells in both groups. We have to divide patients to cured patient and the recurrent patient. And we do the CD4 and the T cells, CD4 and CD8 in both of them and compare. I think there is nothing like that in the literature. I didn't read it.
I totally agree with you. Yeah, I totally agree with you. We are still, we did not so many trial and so many study of the immunity of the peritoneum, and it's probably crucial and essential to try effectively to understand why some of them were cured or were longer survivors. And probably one of the key, as we cannot perform randomized trials in this complex patient every time, is to compare the good patients and the bad patients to try to get information more quickly.
Okay, thank you.
And to say another thing about immunity, there is also an influence on immunity regarding postoperative complication. We are not sufficiently aware about postoperative complication that have a very strong influence of the prognosis. When you have a patients that are in your bed postoperatively for 1-2 months, that is recovering for many weeks, for many months, that did not start again is adjuvant systemic chemotherapy, this patient do bad in comparison to the patient that recover in several weeks. So you also have to take this into consideration when you are operating one patient.
I think if we do CD4 and the CD8 T cells in some patients, in patients before treatment, we may get those patients who may respond and be cured if we get a marker for the immunity of these patients to restrict our effort, physical effort, to those patients who have a strong immunity, like malignant melanoma.
I think that I will be able to present you as soon some results, because we also did recently the first trials of intraperitoneal immunotherapy, and we did many intraperitoneal samples, and of course we measure all the immune elements into the peritoneum, but also into the blood.
Okay, thank you.
Okay, we have a question from Dr. Haitham. Please, if you have a question, raise your hand.
Yeah, now, hello. I have 3 questions. First of all, thanks for the lecture. First question about the small bowel involvement. Do you see it as a contraindication to do CRS complete, even if you can remove all the microscopic lesions? I don't talk about patients who is the mesentery of the small bowel are involved.
It totally depends on the etiology. If you have, for example, a mesothelioma with a diffuse involvement of the mesentery, and but absolutely no tumor nodules on the serosa, regular surgeon, for example, will contraindicate and said, "Oh, it's diffuse. We have diffuse tumor. It's impossible." But we are able now to perform a total parietal mesenterectomy. So, and to perform a CC0 resection even in this situation. So I will do it. For colorectal cancer, it will depend on the tumor biology, of the histology, of the response of systemic chemotherapy, on the magnitude of your cytoreductive surgery. If you can remove everything, but if it's a poorly differentiated tumor, if you have to perform 3-4 anastomosis and 3 sutures on your small bowel, I really think that you should go. For gastric peritoneal disease, if you have not a very high PCI, but if you have a lanitis with a poorly differentiated tumor, and if you have in 3 or 4 parts of your small bowel, you know, the small retraction on the serosa, even if your surgery will not be so extensive, I don't think that you should go on. Okay, and the pseudomyxoma peritoneal, when you have this big amount of tumor, but with a low grade, and that you will be able to perform only a CC1 resection. So you will be obliged to let some, small mucin deposit on the serosa, but in a low grade, you should go on.
Okay, thank you. Second question is about how about patients for, I would say, with colorectal metastasis? Would you plan to do CRS and HIBIC, and you open them and you cannot achieve CT 0? Do you do PIPAC in these patients, or you close them and send them to palliative chemotherapy?
I'm trying, despite the big problem of programmation that we had during 2 years with the COVID, that did bad thing for the development of PPAC that I tried to develop in my institution. I'm trying not to abandon the patient. So if it's the first exploration, and if it received only one line of systemic chemotherapy, I will call the medical oncologist, and we will try to define together the way, if there is one, the way to try to reduce the peritoneal extent if it appears possible. And during this strategy, I'm trying more and more to incorporate PPAC as a neoadjuvant intraperitoneal intensification to try to convert the patient from non-resectable to resectable. And I hope that we will get some fund from the government this year to evaluate this, because we have this project to demonstrate this into a randomized trial.
So the role of PIPAC to convert patients from irresectable to resectable is not valid yet. Is it experimental?
It's still experimental, especially in colorectal cancer. We know that we have some response. We know that we can combine with systemic chemotherapy, even with Avastin, anti-angiogenic therapy. We know that we have a clinical response, but we don't know now if it's really increased the downstaging and if it really offers something to our patients. So we should do phase 3 trials now. The key message is that PPAC alone in colorectal cancer is not working. If you do not combine it with systemic chemotherapy, it will not work. And the big problem is when you are surgeon, is that you should be converted as a medical oncologist, or to really communicate with your medical oncologist, because it's very important that your patient receive every 15 days one cycle, one PPAC or one systemic chemotherapy.
I have another question in this regard, because I'm trying to introduce PIPAC in my hospital. And one point that my oncologist doesn't want to pose the systemic therapy. How to overcome this problem?
Combining PPAC and systemic chemotherapy?
He doesn't. I know that PPAC. The patient should take a pause for 2 weeks to come to do my PPAC and go again to the systemic therapy after 1 week, for example. And my oncologist doesn't like that. He doesn't want the systemic therapy to stop.
You have yes, my medical oncologist also. So I have one solution for ovarian. For ovarian, for example, it's really validated, and I think that we published this, and it's very well tolerated to start your systemic chemotherapy 1 week after PPAC. Especially when you are using cisplatinum and doxorubicin, it's extremely well tolerated. So you can do your systemic chemotherapy and your carbotaxol 1 week after PPAC. So if you are doing PPAC and carbotaxol, your carbotaxol will be performed every 4 weeks, 1 week more than what the medical oncologists are doing. And usually they agree, and they are not upset about the decrease of chemotherapy intensity. For colorectal cancer, I think that you should evaluate what are doing what. So it's very important not to start with PPAC. You will start with systemic chemotherapy, at least 3 or 4 cycles. And if you want to intensify by PPAC, you will introduce your PPAC after that. Usually when the patients begin to not to tolerate so good is systemic chemotherapy. And my experience is that your medical oncologist is usually okay, because you will have 1 less cycles of oxaliplatin, so you will delay the problem of neurotoxicity, but you should not start with PPAC. I agree with them with this, but when you want to intensify, and after that you are performing PPAC only every 6 weeks. So we will do 1 cycles less every 6 weeks. It's not so much.
Okay, thank you.
Okay, do we have any other questions? Please, if you have a question, raise your hand. Dr. Gamal Amira, do you have a question?
Hello?
Yes.
Yeah.
Hello? You listen, you hear me? Thank you for your very nice lecture. You remember we met several times, last time in Rio, 3 years ago, when you went to Mercana to watch the football game. My question is, it was so serious to tell the Prodage 7 with these results, and we know that oxaliplatin for 30 minutes is not effective and very short. How to give these results and you don't do another trial for mitomycin for 1 hour and then you compare the results? This is my first question. And second question, when you have liver metastasis, does this, with peritoneal disease, does this affect your decision in the policy of treatment, or you do the same?
Okay. So I think that if we do not get some fund to do another randomized trials, we will probably do like you suggest. So the problem, and this is the problem of the comparison of the mitomycin C regimen and the oxaliplatin regimen, is that when you are performing the evaluation in another period of time, you do not take into account many things: the progress of the perioperative systemic treatment, the progress of the surgery, the progress of your selection, your patient selection, and leading to a comparison that did apples to peanuts. So of course, we are using now in France a prospective registry that incorporate all the patients that are treated with mitomycin C. But it's always preferable to do comparison into randomized trials. Moreover, I really think that your international Delphi that will give some answer to the expert opinion on the best IPEC that we should use will also probably give more homogeneity and allow us to answer more quickly to some answer. To answer to your second question regarding liver metastasis, in my experience and in what I saw, I don't think that IPEC you increase the morbidity in one case if you do not an extensive liver resection. So extensive liver resection with IPEC usually lead to higher rate of complication. And I told you about what I think about the influence of postoperative complication. But now with the development and the use of sparing liver surgery, usually IPEC had no influence and you can do it without any adding morbidity. And it does not influence the absorption of the drug and the diffusion of the drug.
Thank you very much. Thank you.
Okay, thank you. Do we have any other questions from the audience? Okay, thank you. I think that was it. We don't have any more questions. Thank you for this very informative talk and looking. Okay, maybe Dr. Haitham has one more question. We take one more question. Final question.
Thank you, Sham. Thank you. So another question about PIPAC. Do you see any role for prophylactic PIPAC?
For the moment, we have one question which is not resolved, is the possibility of doing PIPAC following suture or anastomosis. I'm not very confident about this. For one reason is that at the beginning of the PIPAC should, Marc Raymond said that PIPAC will replace IPEC. And he had a very high mortality and morbidity rate, the high rate of complication. So he came back to place the PIPAC as a palliative treatment. And saying that if there is some surgery, PIPAC should not be applied. So we try to evaluate this on pigs, and I did a study on pigs, and we compared after one anastomosis, IPEC and PIPAC. In the IPEC group, we had no fistula. In the PIPAC group, we had 3 or 4 abscesses around the anastomosis. So in my institution, when you are doing just an injury on the small bowel, PIPAC is contraindicated to avoid a perforation. But I think that you will probably see into the literature now some physicians that are using PIPAC regularly that begin to evaluate PIPAC as prophylactic treatment. And for the moment, it does not appear to increase complication. So I think that PIPAC may have so many other applications that I'm not sure that for the moment it should be used as adjuvant or following a tumor resection.
Thank you. Thank you.
And to conclude also, I don't believe to an accurate exploration under laparoscopy.
I do agree.
Yeah. In colorectal cancer, we clearly demonstrated that you miss 12% of peritoneal disease and you underestimate the PCI. So
you cannot do an accurate PCI, of course.
Yeah. So this is the reason why, for the moment, I'm not believing in PPAC in an adjuvant setting, but I can be convinced by someone.
Okay, maybe I'll do it. Thank you.
Okay.
Thank you.
Okay, thank you. I think this was the last question.
Okay.
Thank you, Dr. Olivier, for joining us today. And if you have the time, we sure would love to have you again in the future.
With pleasure. It was a pleasure. Thank you for your attention, your patience, your question. And I hope perhaps in real in Egypt, I will be able to come to see you. But if you want
Yes.
another talk, it will be a pleasure.
Yes. Okay. Thank you, Dr. Olivier.
Bye.
Have a good night, and thank you everyone for attending. Have a good night.
Bye.
Bye-bye.